Hello again, and welcome to the second part of Overview of Physical Therapy. We should just continue in your lecture notes. We're going to be talking about the physical therapist's role and function to start this segment. And what I want to draw your attention to are some of the handouts that are posted in the supplemental handout area. And these are policies from the American Physical Therapy Association. And so what you're going to see here are, for the first one, is the provision of physical therapy interventions and related tasks. HOD means House of Delegates. That's the policy-making body for the American Physical Therapy Association. P just tells you it's a policy. And then 0600 means that it was written or developed in June of 2000. Don't worry about these other two numbers. So it's not that you really have to worry about any of the numbers, but I just want to tell you what they are for. So a policy means that this is what the profession feels like is best practice, or is kind of the way things should function. So related to the physical therapy, this policy describes the three types of people or practitioners who can deliver physical therapist services. So first we have physical therapists, and the professional stance is that they are the only professionals who provide physical therapy interventions. So all those things we talked about in the first segment related to what physical therapy is, only physical therapists can legally provide that. Physical therapist assistants are the only ones who can provide selected physical therapy interventions or treatments, and that has to be done under the direction and at least general supervision of the physical therapist. So I'll talk more about what general supervision means, but again, the physical therapist assistant is the only one who can provide physical therapy treatments as long as they're supervised by a physical therapist. So for example, if a physical therapist assistant chooses to work for a chiropractor or under the direction of a athletic trainer or something like that, they can certainly assist anyone they want, but they would not be providing physical therapy services. That can only be provided under the direction and supervision of a physical therapist. And then finally, physical therapy aide is usually an on-the-job trained person, and they perform certain tasks, again, usually more related to the operation of the physical therapy service. So these are the three types of personnel that we're going to be talking about in more detail. And again, I want to start with the physical therapist and what their role and function is. And initially, they're responsible for interpreting any referrals. You might have heard that word like order or prescription, but we get referrals for people get referred to physical therapy, and then of course the physical therapist decides what they need to have done. In every state in the Union, a person can go to a physical therapist without a physician's referral. There's no need for that from a legal standpoint. Many people are still appropriately referred, so if they're a physician or a dentist, for example, feels like they would benefit from physical therapy services, they should be referred to physical therapy. So if a referral is in place, then it's the physical therapist's job to interpret and understand what the referring practitioner was thinking. Once that referral has occurred and the patient's coming in, again, it's the physical therapist's sole responsibility to perform the initial examination, so doing the tests and measures and anything that would help them figure out what's going on with the patient, taking a history, and then they combine all that information and evaluate it so that they can come up with a diagnosis and a prognosis. And that prognosis then is really meaning, how long will it take, how much better can they get, and how long will that take? And so that leads us very naturally into the development of goals, and then a treatment plan to achieve those goals. So this initial setting up of what we call the plan of care is all the responsibility of the physical therapist. Now the physical therapist can go ahead and apply treatments, in other words, deliver interventions. Interventions and treatment are synonymous terms, like gait training, for example. Or they may decide that somebody else could do that. And we'll talk more about that ability to delegate. But the physical therapist has to decide how how the interventions are going to be delivered and who's going to do it, whether they're going to do it, whether a PTA is going to do it, or a combination. And again, that's the delegation portion. As the patient gets better, or if their status changes in some way and they need to be examined again, have their goals reassessed, and have the plan of care adjusted, that's all, again, the sole responsibility of the physical therapist. So even if you as a PTA were seeing a patient, after a period of time, the physical therapist needs to see them again to update the plan of care and make sure things are moving the way they're supposed to, the patient's getting better the way they're supposed to, and that they're moving toward a discontinuation of treatment. So that's the discharge plan. Probably discontinuation is a better word than discharge, but they're going to discontinue a certain episode of care, and that's the responsibility of the physical therapist to determine that and document that discharge status. That's also often done in conjunction with the physical therapist assistant. And then finally, the physical therapist is responsible for oversight of all documentation. So many physical therapists will do this by virtue of what we call co-signing. So if a physical therapist assistant writes a note and the physical therapist wants to indicate that they understand what the PTA has done, that there's been some collaboration, they will co-sign the note along with the physical therapist assistant as a way to indicate their agreement and supervision. So that's really, those are the responsibilities of the physical therapist. And I go through those because as the PTA, you need to have a very clear idea of what, not just what your role is, but what the physical therapist's role is, so that you can best understand how to collaborate and work on a team and yet still keep clear lines of responsibility in place. So let's go on to the physical therapist assistant's role and function. And again, here we're going to take a definition out of one of the APTA policies. And how do we know it's an APTA policy? Well, we look up here and see HOD for House of Delegates, right? It's a policy written in June of 2005. So this is direction and supervision of the physical therapist assistant. And so it defines the physical therapist assistant as a technically educated healthcare provider. They assist the physical therapist in the provision of physical therapy. So pretty much related to what we saw before. And it goes on to give a little bit about the qualifications. Graduate of a physical therapist assistant associate degree program, so it determines that it's at the associate degree level. This program has to be accredited by the Commission on Accreditation in Physical Therapy Education, which we pronounce as CAPTE. We abbreviate as CAPTE. So this accreditation process ensures quality for education. It ensures that the students are going to be able to, when they complete the program, that they will have all the skills and knowledge necessary to function as a physical therapist assistant. So we're going to talk about how the PTA functions. We're going to talk about the data collection and treatments that they perform and the ones they can't perform, and then a little bit about how they might change or modify some of the treatment plan. So this is where we're going to get back and talk about that term general supervision that you heard earlier. So the physical therapist assistant has to function at least under under the general supervision of a physical therapist. So direct supervision means that I'm the physical therapist, I'm in the same building with you, I'm in the same room with you, that I'm in the same physical space, so that if you, the PTA, needed something, had a question, you could immediately come and physically find me and take me back, and I could help you. General supervision means I don't have to be in the same building. I could be across town, I could be miles and miles away, as long as you could access me telecommunication-wise. So if you had a question, you could access me via telecommunication, and then I could provide you help or assistance. So that's what general supervision is. And again, at a minimum, the PTA has to have general supervision of a physical therapist. Now I do want to go on and talk a little bit about the specific rules related to general supervision in the Wisconsin State Practice Act. And again, this is not the same in every state. This is specific to Wisconsin. And there's a section in our Practice Act that describes how physical therapist assistants and aides or unlicensed personnel need to be supervised by the physical therapist. So just a quick word about the difference between the Practice Act and the APTA policies. The Practice Act is the law. It is the minimum that you have to legally do. There's no getting out of it, no interpretation. It just has to be done this way. APTA policies are written more at kind of an ideal functional level. It's the, what's considered best practice. It's the opinion of the professional association. So we're certainly strongly encouraged to follow it, but it's not like it's illegal. There aren't no one's going to take you can't get arrested if you don't follow APTA policy. But the Wisconsin State Practice Act or any state practice act describing practice has to be followed. So again, that's what we're going to talk about now. Some of the rules in the Wisconsin Physical Therapy Practice Act that describe the oversight of the physical therapist and the physical therapist assistant by the physical therapist. So one of the rules is that if, let's say, you and I are not working in the same building, at least every 14 calendar days, I need to come and see you and have a face-to-face talk with you about how things are going with all the patients, any questions you have, how your skills are going. I might observe you treating some people, just to kind of make sure that we are having an opportunity to collaborate in patient care. In addition, I also need to make sure that I'm seeing every patient that I've delegated to you. And that timing is a little bit different. I have to see a patient at least once a month or every 10th treatment day, depending on which is less or sooner, I guess. So if you were seeing someone 2 days a week, then I wouldn't get to the 10th treatment day for 5 weeks. So I would need to see them earlier than that, presuming 1 month that there's 4 weeks in a month. I would have to see them a little bit sooner than that. So the physical therapist has to be kind of keeping track of this, along with help from the PTA, to make sure that they're meeting with the PTA every 2 weeks and seeing every patient at least once a month or every 10th treatment day. So if you're seeing a patient every day, for me, then I have to come in again and see the patient every 2 weeks. And the purpose of this certainly is so that the physical therapist can keep track of the patient's status, how they're progressing, any changes that need to be done in their plan of care. And remember, that goes back to being one of the sole responsibilities of the physical therapist. Now, this sounds like a lot of work. It is. And for that reason, there's another rule that says that a physical therapist can't supervise more than 2 full-time physical therapist assistants. So the term full-time equivalent, or FTE, means a person who's working 40 hours a week. Clearly not everybody works 40 hours a week. So let's say there was one PTA who did work 40 hours a week, and then 2 other PTAs who each worked 20 hours a week. I could still supervise all 3 of those people because together they add up to 2 full-time positions. The idea here, of course, is that it's not really just the therapists I'm supervising, but I'm responsible for all the patients on their caseload, in addition to the patients I'm keeping on my caseload. So that's a lot to manage. And so the purpose of the Practice Act is not to help out the therapist, it's to protect the patient. And so this rule is designed to make sure that each patient has enough of the physical therapist's time to make sure that they're getting adequate care. And then finally, the physical therapist is responsible for making sure that there is written policies about all this communication so that everybody knows what's going on. All right, so those are some of the rules in the Wisconsin State Practice Act. So let's say that the PT wants to have the physical therapist assistant see a patient, and they want to do either data collection, which is like muscle testing, goniometry, something like that, vital sign measurement, and they want them to do interventions or treatments. So how do they decide if it's okay for the PTA to do that? Well, we have a couple things we can look at. Again, in the Wisconsin Practice Act, it requires the physical therapist look and make sure that they understand the PTA's education, their training, which might include continuing education or on other specialized on-the-job training, and experience. So those are kind of the three major things. And this primarily is focused, of course, on the physical therapist assistant. In the APTA policy that looks at supervision and delegation, we looked at that before, there's a whole other list of things. So you can see the top bullet includes the PTA's education, training, experience, and skill, but it also looks at elements related to the patient. And a lot of these kind of blend together, but how acute, in other words, how new is the patient's problem? How complex is the patient? How critical is the patient? And so that, of course, leads into how predictable the outcome of the treatment would be. So if a PTA applies a treatment to a very unstable patient, the outcome may not be the same on one day from one day to the next, because the patient's changing so much. So those two really blend together. The setting in which the care is delivered also could inform us about what kind of patients would be there. So for example, if you had a child in a school setting where they have a developmental disorder and they're in a school system and they're getting treatment, that's very different from a child with a developmental disorder in the neonatal intensive care unit who may be critically ill, whose vital signs may be they may be medically unstable. So while it may be a similar type of patient, the setting and then the stability and complexity of that patient are very different. So, it might be appropriate for a PTA to see a child in the school setting, but perhaps not in the neonatal intensive care unit. There certainly are federal and state laws, that's what statutes are, laws that have an impact on how we might delegate. Liability and risk management is really important. I need to think about that, and I'm going to talk a little bit more about that in just a minute. And then what's the mission of the therapy, and then how often does the patient need to be seen again. So the physical therapist needs to take into account the abilities of the PTA and the status of the patient. I mean, that's basically what we're talking about, and decide if it's appropriate for that patient to be seen. According to, again, APTA policy, there are some interventions that the professional association has said should only be done by the physical therapist. And basically there are three. Out of all the many types of treatments we might do with a patient, there are three that the APTA has said, and by APTA I mean the profession as a whole. This isn't developed by just a couple of people. This is 400 to 500 people bringing their collective wisdom together and debating about this. So it's the voice of the profession saying that these three treatments really shouldn't be done by a PTA. They should only be done by a physical therapist. So one of them is spinal manipulation and mobilization. Another one is peripheral joint mobilization and manipulation. And then the third is sharp debridement, so cutting off tissue off of an open wound. And the reason for this is not that the PTA can't physically learn how to do these skills and cognitively understand them, but because these are the types of treatments that can result in very rapid change in the patient. So let's take, for example, the sharp debridement. I can guarantee you that the status of that wound will be dramatically different before and after you cut some of that tissue out of it. And so if we reflect back to what we talked about earlier about the responsibilities of the physical therapist, only the physical therapist can re-examine that patient. So the idea is that these three types of treatments result in very dramatic changes immediately in a patient and require re-examination. So if we contrast that with doing a strengthening exercise to the quadriceps, yes, we hope ultimately the patient has a change in their status, that they get stronger, but it's not going to happen in that one treatment session. And there'll, again, be time in 2 weeks or whatever for the patient to get re-examined by the PT. But these treatments require or may cause dramatic changes immediately, and so the patient needs to be re-examined, and so that's why the profession has stated these three things shouldn't be done. Now that doesn't mean that is without controversy. I would say particularly for peripheral joint mobilization, there are many, many people, many physical therapists who do delegate that to physical therapist assistants. Some delegate only very mild or gentle mobilization with a theory that it won't change the patient's status much. So as you get out into the clinic and you see different things, you will certainly come into contact with this idea. All right, and then finally, how do we modify the physical, how can the PTA modify or change the plan of care or what they're going to do with the patient? Basically, the physical therapist sets up a plan of care and goals. So they describe, so they kind of set up some goalposts about what they will allow to be done with the patient and what they won't. And so if the plan has been set up fairly broadly, like you see this gentleman here doing some gait training in the parallel bars, if that's the plan to do gait training in the parallel bars, then that's pretty much where you would have to stay. If it just said gait training and it didn't say in the parallel bars, then the PTA could use their judgment and kind of change what they're doing with the patient based on the PTA's judgment. But if the PT has developed more stringent requirements, like gait training with crutches, that's the only thing that's in the plan of care, then that's what the PTA has to do unless they get permission to change it. Now, another reason, I think very common sense reason, that the PTA might do something different than what's written in the plan of care is if it's uncomfortable for the patient or if it's dangerous for the patient. So certainly I would want a PTA to recognize if a patient was not safe doing something, or if they'd maybe had a change in status and it wasn't safe, or it was uncomfortable for them to do something. I would want the PTA to recognize that, and that would be one of the things I would expect them to come back and talk to me about. So that kind of summarizes the role of the PTA. And then what I want to finish up finally with is the role and function of the physical therapy aid. And I think a lot of times we use the word aid. Legally, the title in Wisconsin is unlicensed personnel. APTA uses the title support personnel. And the definition is someone other than a PT or a PTA, so not licensed either as a physical therapist or physical therapist assistants, and they perform tasks under the direct on-premise supervision of the physical therapist. So that means the physical therapist is there every minute, all the time, to see what's going on and to be able to supervise it. Now, in Wisconsin, the term unlicensed personnel doesn't mean they have no license at all. So for example, if a massage therapist or an athletic trainer who is licensed in their own field works in a physical therapy clinic under the direction and supervision of the physical therapist, they are considered unlicensed for the purpose of the Physical Therapy Practice Act, because they are not licensed to deliver physical therapy. They're licensed to deliver massage therapy or athletic training. So that gets a little confusing to people, but that's basically the idea, is that the only people, going back to our original definitions, who can provide physical therapy are physical therapists and physical therapist assistants. Unlicensed people who aren't licensed as a PT or a PTA can do some limited patient care and interaction, but it's under very strict supervision guidelines. So they can't do anything that requires, they can't basically make judgment calls or decisions about patient care, at least not in the same way that a PT or a PTA would do it. So in Wisconsin, again, this is out of the Wisconsin Practice Act, if a physical therapist wants to have an aide help out with treating a patient, first of all, they have to make sure that that aide is able to do it. And so they have to verify that. In a work setting, the aide would actually have to go through competencies, much like the checkoffs that you all are going through to make sure that they are competent in delivering the treatments. When the PTA says to the aide, I want you to go over and work with Mr. Jones and work with him on his leg strengthening, they can't just say, go do some leg strengthening. They have to say specifically what muscle group, what position do they want the person in, how much weight, how many repetitions, how long should they work with the patient, anything like that. None of that can be left to the person's discretion. That's very different than what it would be like for a PTA working with them. They could definitely just say, go work on a strengthening program for their legs, but that's not the case. So you definitely have to, the physical therapist has to give a lot more direction to the unlicensed personnel or to the aide. And to make sure that it's really appropriate, the physical therapist has to see the patient before and immediately after the aide has worked with them. So before, to make sure the patient's okay and ready to go, and then after, to see the outcome. So it's very different than supervising and delegating a physical therapist assistant. And in Wisconsin, a physical therapist assistant cannot delegate to an aide. Now in Illinois they can, so that's a little bit different. And then finally, there is a total number. How many PTAs was the physical therapist able to supervise? Right, 2 FTEs. So between the aides and the PTAs, the maximum number that the PT can supervise is 4. So if they're already supervising 2 PTAs, they can only supervise 2 aides. Again, this is to protect the patient and make sure the physical therapist doesn't have 80,000 patients that they're trying to keep track of through all these other people. So that pretty much wraps up everything that we're going to look at for today on this video. And there is on this presentation, there is a video called You Can Be Me, and instead of playing it here, I'm going to let you go ahead and look under the video tab and find that video, and it talks a lot about physical therapists and physical therapist assistants in different practice settings. And again, it just kind of rounds out, gives you a little more information kind of about what you're getting into and what the opportunities and possibilities are in the profession. So it's very upbeat. I hope it's inspiring for you, and I look forward to seeing you and talking more about this in person.